My
Go ahead.
sir, my case presentation is on a 70 years old male, chronic smoker, COPD, posted for a laparoscopic cholecystectomy.
Cholecystectomy.
Here, the chief complaints what the patient might have is abdomen pain, nausea, and vomiting. A history of presenting illness. I'll ask for history of abdomen pain, for how long it has been there. If it is a sudden in onset, how is the nature of the abdomen pain, intermittent or what? And the area of the abdomen pain, whether it is around the periumbilical area or it is in the right upper quadrant. Usually, this cholecystitis aggravated by spicy and oily foods and relieved by medications. And about the history of vomiting, how long it has been there, about the episodes, color of the vomiting, whether it is a projectile or non-projectile vomiting. Usually it is a non-projectile in nature. And the contents of the vomit, whether it contains food particles or any blood stained hematomesis like presentations. Then history of fever, if it is there, we need to rule out about the grade, intermittent or continuous, chills and rigor presentations, and then it is relieved by medications or not. Then coming to like history of any breathlessness, what the patient might have, whether it's like lasting for around 8 years or 10 years like that, and if the patient is on any drugs, and about the grade of the breathlessness, what the patient is having, according to modified medical research council mmrc grading, and about the episodes of exacerbations what the patient have, then the aggravating factors like any cold or dust is there. Then about if the patient is having cough with expectoration or not, and how long it has been there, whether it is like the nature of the sputum, whether it is a mucoid in nature, whether it is a scanty or purulent type of sputum, and the color of the sputum, if it is a like white or green, then whether it is foul smelling or not, and the quantity of the sputum what the patient is producing, and if there are any seasonal or postural variations in the cough to differentiate from asthma. Then coming to negative history, like extrapulmonary considerations when coming to COPD, like the patient is having any nocturnal awakening with breathlessness, any loss of weight, loss of appetite, any evening rise of temperature the patient is having. Then about the history of syncope, palpitation, and chest pain to rule out any parapulmonary right heart failure presentations. Then also the any history of leg swelling on and off. Then any confusions or headache, altered sleep patterns, if the patient is having to rule out the CNS symptoms. Then any history of like yellowish discoloration of eyes and the urine and passage of black or clay colored stools, we need to ask. Then coming to past history, we need to ask any history of hospitalization for acute exacerbations of COPD. If there are any hospitalization episodes, we need to rule out what was the therapy given. Oxygen therapy was just only a face mask or a face mask and IV drugs, or the patient was ventilated, was under invasive mechanical ventilation or not, and how many times within 1 year the patient had exacerbations and he went to a like ER, uh, and the type of treatment what the patient is on, whether he's just on only one type of MDI inhalers, or he's taking two different types, or he's also taking two different types along with oral steroids or anything to rule out the type of treatment the patient is having and the grade of treatment he's under it. Then other history like diabetes, hypertension, CAD, and the tuberculosis, asthma has also tuberculosis has been should be ruled out, and other history of food allergy or tablet allergy also should be ruled out. Then about the personal history, mixed diet and bowel bladder habits, and sleep patterns. If the patient is having good adequate sleep patterns or his sleep patterns is interrupted, then coming to the smoking history, how long the patient has been smoking and the number of packs per day what the patient has been smoking in terms of pack years. And we can also calculate smoking index by asking a number of cigarettes the patient is taking per day in past how many years. And this helps in grading the type of smoker he is. Then we also need to rule out the socioeconomic status. Coming to the general examination, uh, I'm examining the patient in a sitting position, whether like the patient is comfortable or not. Then about the conscious patient is conscious oriented and afebrile or not. Any use of accessory muscles for respiration should also be seen on general examination. Then we have to rule out the vitals and height, weight, and BMI. Here, while coming to the vitals, the respiratory rate is very important. Like there's a regular type of breath or a pursed lip type of breathing, abdominothoracic type of breathing we need to rule out. Then other examinations like palarectric cyanosis clubbing. Since the patient is a long-standing, I mean, it's a chronic smoker, we need to rule out the clubbing also. Then a lymphadenopathy and pedal edemas. Then JVP, any JVP rise in this patient should be ruled out. And we need to look for IV access also. If the patient is on chronic admissions, we might have difficult IV access due to thrombosed veins. Coming to the systemic examination, respiratory system inspection, upper respiratory tract, we need to rule out like bilateral nares and mouth openings and oral cavity. We need to look for the teeth stains, halitosis, anything like that. Then the chest shape. Usually these patients might have a barrel shaped chest. Then the trachea usually appears to be midline, and the use of axillary muscles should be seen. Then about the bilateral chest movements on inspection, if it is symmetrical or not in the during respiration. Any supraclavicular hollowness or intercostal recessions can be seen. Then any dilated veins or pulsations or swelling scars over the chest wall should be ruled out. Coming to palpation, we need to confirm the inspectory findings, and we need to go for a chest expansion in normal position and during the deep inspiration. Uh, then AP diameter and transverse diameter of the patient should be measured. Then we need to check for the bilateral vocal fermenters and bilateral chest movements if it is equal or not. Coming to percussion, usually resonant. In case of emphysema, we can expect a hyperresonant note. Then we need to rule out the liver dullness, like normal liver dullness or not. Usually in the fifth, seventh, and the ninth intercostal space, starting from mid-clavicular line, anterior axillary line, and mid-axillary line. On auscultation, like vocal resonance, if it is equal or bilateral equal or reduced, then bilateral air entry, whether it's a normal vesicular breath sounds or not, we need to look for any rhonchi or any other added sounds, like crepitation and thing. Um, airway examination. Airway examination, sir, in sitting position, we need to look for any craniofacial deformity, bilateral nares normal or not, any loose tooth or dentures, mouth opening and malampati gradings, then TMJ joint examinations and thyromental distance. We need to look for the neck movements, then upper lip bite test. All these airway examinations should be done. Coming to like serious examinations and serious examination, all this inspection, precordial in normal size, apical impulses visible or not, any engorgement of superficial veins and carotid pulsations you have to see. Palpation, we need to look for the apex beat. Like usually it is in the fifth intercostal space, 1.2 centimeter needle to mid-clavicular line on the left side. No parasternal heave, no palpation, no palpable thrill or any pulsations. Auscultation, we need to look for S1, first and second heart sounds, any murmur or added sounds present or not. Coming to abdomen examination, inspection, we need to look all the patterns of the abdominal wall. Is it moving with equally with the respiration? Any dilated veins, and we need to look for the umbilicus. If it is normal and it is midway between the xiphisternum and pubic symphysis, we need to look for any visible scars, swelling, and pulsations. On palpation, we need to confirm the abdomen findings, inspectory findings. Then abdomen is it soft, any tenderness, any guarding or rigidity, fluid thrill, and rebound tenderness we need to look for. Coming to percussion, tympanic note might be present, and liver span, if it is like 10 to 12 centimeters, normal or not, any hepatomegaly is there. Then we also can look for Murphy's sign. Then any shifting dullness of fluid fill, and auscultation, bowel sounds can also be heard. Uh, I'm going for a bedside pulmonary function test, sir, like Sabra's breath holding test, then single forced expiratory time. Coming to CMS examination, higher mental functions, cranial examinations, speech, tone, power, and reflexes, everything need to be checked, and also the spine. Coming to summary, my case is my patient is of 70 years old male, chronic smoker with abdomen pain associated with fever and vomiting, also having a features of COPD, optimized with the medications, now posted for a laparoscopic cholecystectomy, sir. So I would like to optimize the patient before taking for surgery. Yes, sir.
So far you have only summarized the history and your examination findings.
Yes, sir.
Your management, how are you going to manage this patient? What are the plans for your management of this patient?
Yes, sir. I would like to go for some investigations. Like complete blood count, renal function
So
test,
you
and
can pass off that as a basic pre-surgical investigations which are done for all patients. Anything
yes,
specific
sir.
to patients with COPD you want to do?
Um, sir, I want a pulmonary function test and spirometry, sir.
Is pulmonary function test always necessary for all the cases of COPD?
Uh,
Go
Can't you
for
not
ECG
evaluate the
and
patient
echo.
from your so much of history taking you have done? Can't you not evaluate the patient's cardiovascular respiratory conditions from his effort tolerance, whether he is able to climb a flight of stairs? What is his basic respiratory rate at rest? Is he tachypneic all the time? Is he having any persistent lips breathing? Even 6-minute walk test, if you ask him to do and do the SpO2 measurement, you can easily find out. It is not always compulsory to do a pulmonary function test just because the word COPD is mentioned in that scenario. Okay, so you must use
yes, sir.
your clinical assessment more than depending upon, because there are a lot of controversy. Pulmonary function tests are not routinely done. That is why it is not a routine investigation done in all patients of even COPD. Okay,
Yes, sir.
so you
Yes,
must go with your clinical evaluation, and the challenges in this are, what is the most important challenge? What is the one investigation
age
which
of
you have to compulsorily do and document before you would take up this patient for lab cholecystectomy?
sir, I would like to do echo, sir. Since the age
Echo.
of patient is 70,
Anybody else? I would not agree with that. Echo, of course, it's going to show the echo is done for all the patients, but in a COPD patient coming for a laparoscopic procedure, what is the investigation which is required in the pre-operative phase and to be
Acid-based gas
documented?
analysis.
ABG,
Huh?
sir. ABG.
Acid-based gas.
ABG, acid basal, arterial blood gas analysis to see whether he is having a persistent hypercarbia. Okay,
Yes,
these
sir.
patients may be chronically hypoxic with hypercarbia. Okay,
Yes,
respiratory
sir.
type 2 failure may be there in these patients. That has to be
Yes,
ruled out. So ABG is a must in these patients rather than pulmonary function test. Okay, and once
yes, sir.
you know that he is persistently is having a PCO2 of 50 or 55, not within the normal 35 to 45 range, then you have to adjust your technique to see that the lab procedure does not aggravate the hypercarbia status, isn't it? Because you are going to do CO2 insufflation, so your
Yes, sir.
request to the surgeon to insufflate carefully, and your ventilatory techniques are the two things which are going to determine how the carbon dioxide levels can be controlled to maintain what is called the permissive hypercapnia levels. Okay, that is the most important thing the examiners expect you to answer, not about the other things. Okay, so that is the thing that you have to, and your presentation is a little bit jumbled. You are talking something about these respiratory findings, then you are suddenly saying whether he is jaundiced or not, whether there has been abdominal pain. So either first talk about the surgical condition, then go to the medical complication that is existing in that patient. So like that you segregate and present your findings instead of combining suddenly Murphy staying here and then going for sputum examination, sputum, all like that. Don't mix up. So make your goal clear that you have a patient here who has a chronic COPD. That is the thing. And he has been posted for lab chole. The reason for that may be a repeated cholecystectomy or a gallstone. Okay, these are the reasons why they want to do a lab cholecystectomy in this patient. So you need not waste your time in elaborating too much of the surgical description of the patient, like I will palpate and see whether he had pain in the umbilicus or in the right hypochondrium. All that is not required in the examination. You can just say that these are the indications for which is posted. So our aim is to how to manage this patient because the lab poses the challenge of the possibility of increasing his carbon dioxide level by CO2 insufficiency. That is the reason why this sort of cases are given both in theory questions as well as in the clinical examination. They want to find out how you are going to manage. So how are you going to tackle this patient? What is the, first of all, what is the technique of anesthesia you want to give for this patient?
Sir, I would like to go with general anesthesia.
General anesthesia. Commonly, that is a routine thing that we practice in all patients. We go for general anesthesia, right? You want to do endotracheal intubation anesthesia, or can you use supraglottic airway devices in that? That is the next thing that.
Yes, we can use a second generation supraglottic devices like Procelia.
That is always having a risk, but it has been reported that you can use second generation or third generation LMS with facilities for draining of the gastric secretions if they come to the pharynx. Then, so, but that is more theoretical rather than many people, unless they are very experienced in that, they don't prefer to use the second generation LMA also. They prefer to go for a endotracheal intubation so that they can control the ventilation better with the ventilatory strategies. So, as I told earlier, what are the requests that you will make the surgeon to put to the surgeon to reduce hypercarbia?
Sir, I the rate of insufflation what the patient is having.
Rate of insufflation and intra-abdominal pressure. Okay, these are the two things that you have to request and discuss with the surgeon, that it should be a slow insufflation with carbon dioxide, not more than so many ml per minute, and the intra-abdominal pressure should be ideally kept below
15 mmHg, sir.
10 to 15. Maximum, in this case, it will be preferable to keep it between 10 and 12 millimeters of mercury. Okay, so that the diaphragmatic extension is also not very much impeded. That will also account to preventing the basal zones of the lung expanding and producing a sufficient ventilation. Okay, so both the insufflation rate as well as the intra-abdominal pressure measurement to be maintained, to be discussed with the surgeon. That is the first and foremost thing. Then coming to your management of GA, what are all the things that you have to take care? From the routine technique of general anesthesia, where you give an IV induction agent followed by a relaxant, intubation, maintaining with oxygen, nitrous oxide, and a volatile anesthetic agent, giving narcotics for pain relief or paracetamol infusion, and then finally reversing the patient from the non-default signature block and extubating. This is a real regular sequence of events that you follow. What are all the, in this sequence, what are all the things you have to alter for this patient with COPD?
Sir,
So
I
coming to the
maintain very
pre-medication,
good
do
health,
you want
sir.
to give any pre-medication for this patient?
Yes, sir. I would like to give benzodiazepines on the
No
night before
diazepam.
surgery.
Hmm.
Low
Why
dose
you want to give
benzodiazepines.
benzodiazepines?
Sir, the fear of surgery itself, the
To
patient
allay
might
the
hyperventilate.
anxiety, you must use the correct terminologies, okay? To allay the anxiety of
Yes,
the patient,
anxiety.
right? Can this have any effect on the respiratory system?
Uh, Sir, since it is a low dose,
Hmm.
since
So
it
you
is a
can say,
low
no, it
dose,
will not affect, it is not going to cause any respiratory depression. And the dose I am going to get prescribed, they say 0.02, 0.25 mg, it is not going to cause
2,5
any
mg.
respiratory depression. But anxiety can induce a bronchospasm or hurried respiratory breathing, which is not conducive for this patient. So I would not like to have the patient in an anxious state. So I would prescribe the benzodiazepam. Okay, right, agreed. On the day of surgery, this is pre-op night. Supposing surgery
Yes,
is the
sir.
morning 6 o'clock. What
Yes, sir.
pre-op instruction you
Uh,
want to give?
Sir, first I would like to like the patient to stop, ask him not to smoke even on the day of
Okay,
surgery, sir.
that is a
Then
preparation that
about,
has to be done well in advance
yes, sir.
before at the time of
Yes, sir.
assessment itself. Now we have come to the stage of taking up the patient for surgery. So
Yes, sir.
stopping
I'd like to give
smoking, giving a pre-operative chest physio, incentive spirometry,
physio,
all
sir.
that is pre-op preparation. Now it is pre-anesthetic preparation on the day of surgery.
Sir, I'd like to give proton pump pantoprazole
Okay,
40 milligram oral, sir.
okay.
Then
Hmm.
metoclopramide 10 milligram oral,
Okay.
sir.
Hmm.
Like
That is given for all the
prokinetic.
patients. This is an elective surgery also, but you are
Yes, sir.
justified, no
Uh,
problem, you can give. Hmm. But what
I
other
would like to
important thing, being a
continue
COPD patient,
the
what other
double,
instruction you have to give?
sir, to continue the all MDI inhaler
That is
uh,
very important.
14
Even if
weeks,
he
sir.
is not having any wheezing or any problem, if he has been on regular usage of any steroid inhalers or bronchodilators, that should be administered before the patient comes to the OT, at least 30 to 45 minutes before surgery. That is a very important preparation in these patients. Okay. So that is
Yes, sir.
the thing that you should not forget. The examiners expect you to say that. Right. After using those inhalation drugs, patient has come to the OT. Now tell me how will you proceed?
Sir, uh, I need to set up the theater, sir. Routine machine check. I will prepare the drugs, sir,
Okay, okay.
and monitors.
Hmm.
Uh,
So the exam, the first
yes,
answer that you are expected to say when the examiner says patient is on the OT table, I will attach all the monitors and record the basal parameters and document it. Okay,
yes, sir.
that is first. You start like that, then you will not get into any problem of how do you know what will be the BP, what will be the O2 level, whether the patient already has a low saturation or not. How do you know? All the questions will not come if you routinely say that I will attach all the monitors and record the parameters and document them. Okay? So you know the basic room air saturation, you know the basic heart rate, blood pressure, and if you have attached an ECG to the chest, you can find out the respiratory rate also from the expressions of the chest, and everything has to be documented. Right. Now your plan is GA with endotracheal intubation. So what is the drug of choice for induction?
Sir, I'd like to go with the propofol titrated to the
Propofol.
effects, sir.
Hmm.
Yes, sir.
So propofol
Then
need not cause any hypotension.
yes, sir. It might cost, so I'd like to go with the titrated doses, sir. Like
Titrated dose.
1.5 milligram per kg, like
And what
titrated to
other
effect, sir.
pre-treatment you have to do if you are going to inject propofol?
I'd like
Injection
to
into the
give
peripheral vein. Hmm.
Xylocard 1.5 milligram per kg.
So you first
As an
pre-treatment with
antidote.
Xylocard is necessary to prevent the vein that is going to cause by the injection of propofol. And any other agent, supposing patient says he often gets the wheezing very, very easily. At least he has to use the inhaler 2 or 3 times a day. That amount frequency of bronchospasm he goes in for. If that is the history, what will be the ideal drug to use?
For induction, sir.
Induction. Yeah, we are only at the stage of induction.
I'll go with the ketamine, sir.
Only with ketamine or combination of
ketamine with the glycopyrrolate combination, sir.
Glycopyrrolate is not a combination for that. It is a preventive drug to prevent the secretions of ketamine. Okay, but any other induction agent, can it be combined with ketamine, which has a common combination name of part of that ketofol? Okay, ketamine plus propofol.
Ketamine.
It's called ketofol. 50% of ketamine with 50% of propofol has a advantage of decreasing the hypotension caused by propofol alone. At the same time, decreases the hypertensive response produced by ketamine and also reduces the requirement of ketamine. Thereby, emergence delirium is also very much avoided. Okay, so these are the advantages of combining ketamine with propofol, which is called ketofol 50% 50% combination. That may be the best drug if the patient has history of frequent attacks of bronchospasm requiring usage of the inhalers, which has already been administered to the patient before coming to the OT to avoid that. And lignocaine pre-treatment with the full dose of lignocard, like 1.5 milligram per kg body weight, at least 90 seconds before induction agents, will also help in avoiding the stimulation of the upper airway while doing laryngoscopy and intubation, which may also precipitate an attack of bronchospasm. Okay, so that is all the answer that may be expected to know if these questions are asked. So the modification we are going to do at the induction level is a combination of ketamine with propofol will be the ideal. But if you do not get the drug, you need not mix it in your own thing way, but you safely give only propofol in a titrated doses and go ahead with the induction. Okay. Right. What about the relaxant for intubation? Which is the ideal agent for relaxant? The airway.
Sir, since it is laparoscopic cholecystectomy, a short procedure, I would like to go with atracurium, sir.
Atracurium, what is the danger of atracurium?
Release is there, which
may cause bronchospasm or it may stimulate bronchospasm, isn't it? Histamine release and bronchospasm. So a patient with COPD already who may have a bronchospastic attacks, is it advisable to go for atracurium, or do you have a better drug nowadays available which with less histamine release?
Cisatracurium.
Cisatracurium is a drug of choice. So that is the drug that you can use so that it can be easily reversed without difficulty, as well as it has a lesser potential for histamine release. So what is the dose of cisatracurium for intubation?
0.75 milligram per kg.
0.15 milligram, 150 micrograms. Okay. Atracurium 0.5 milligram, 0.5 milligram is the intubating dose of atracurium. This is more potent than atracurium. So cisatracurium dose is only 0.15 milligram per kg body weight. And that has to be given, and you can ventilate, and then you can do a scopy gently. What is the precaution you have to take in laryngoscopy in a COPD patient?
Minimal manipulations can be done, sir.
Minimal?
Sir, we need to avoid the laryngoscopy.
Duration of laryngoscopy should be restricted to not more than 15 seconds, ideally. Okay, so you should do a quick laryngoscopy and intubate the patient, ideally between 15 and 30 seconds to avoid the upper airway irritation. Okay? And in my practice, what I used to do is I used to apply xylocaine jelly to the tip of your McIntosh laryngoscope blade, where it is going to be resting in the vallicula, and also spray 4% xylocaine or 10% xylocaine spray, which is available into the upper trachea to prevent the endotracheal tube stimulating the upper airway and causing a bronchospasm. Okay, so that all can be. That is the modification that you can do. Quick intubation, spraying the vocal cords and the upper trachea, and applying xylocaine jelly to the tip of the laryngoscope. All these measures to prevent the irritation of the upper airway. Right. Once the tube has been secured, what is the ventilatory setting you want to do in this particular case? COPD patient with laparoscopic procedure. What are all the modifications you do from your conventional mechanical ventilator settings?
Pressure control mode, sir.
Pressure control.
Hyperventilation modes. Little bit high.
Hyperventilation.
Hyperventilating the patients.
See, always you must say
Because
about the respiratory rate. You will set IE ratio, tidal volume, PEEP. That is how you must describe the ventilatory settings. Okay. First of all, the choice somebody said pressure control. Okay, agreed. What about the respiratory rate? Is it going to be higher than 16 or less than 16?
18, sir. Higher than
18. Okay. What about the IE ratio?
we can prolong.
You must keep a longer
we also have
expiration
risk
time.
of
Okay?
also
That is the most important thing. 1:3 is the ideal IE ratio, inspiratory to expiratory time. Expiration should be longer because these people have problem in exhaling the carbon dioxide. Okay, and minimal tidal volume. Okay, it should be only 6 to 7 ml per kg body weight. So
Peak.
slightly higher respiratory rate, longer expiratory time, and smaller tidal volume is the best method with a pressure control ventilation with a minimal PEEP of 5 centimeters. Okay, so all these things will help in adequately eliminating the carbon dioxide. So the hypercarbia is the important complication that can happen in this particular patients with the going in for laparoscopic surgery. And try to avoid too much of narcotics like too much of fentanyl or your morphine should be avoided because these patients are
nausea, vomiting.
more sensitive to narcotics and going for respiratory depression in the post-op phase. Okay? So nowadays we have the very short-acting narcotic like remifentanil, which is available, and people have started using it quite frequently now. So intraoperative infusion of remifentanil, continuous infusion will take care of the pain. What is the dose of remifentanil? Because nowadays it is available in the market freely here. You must know all the dosage, how to use it. What is the presentation of remifentanil? I showed you in the ASCII last class. What are the doses at which the drug is manufactured and available in the commercial market? Is it a liquid or a powder?
Powder, sir.
It's a lyophilized powder. Comes in doses of 2 milligram, which has to be diluted, and then you can use it as a slow infusion at the rate of 1 microgram per kg, 1 to 2 microgram per kg per hour. Hour or minute?
Per minute, sir.
Minutes,
Per
sir.
minute. Sorry, per minute. Okay, so that is the dilution at which you have to use. So preferably you should have a infusion pump so that you can use it and give it at the right age. But the only precaution you have to take if you are taking giving remifentanil is, what is the precaution you have to take? You have to know the context sensitive half-life, when to switch it off, and also you must give rescue analgesia in adequate doses before you switch off that, because the analgesic property of the drug will vanish very soon after you stop the infusion. So patient may experience excruciating pain if what is called the rescue analgesia is not given adequately before stopping the infusion. Okay, so you have to give a stiff dose or required dose of fentanyl or other drugs like tramadol or paracetamol, and then try to switch off this so that patient does not experience severe pain on stopping the infusion. Okay, and
Yes, sir.
reversal. What are the precautions you have to take during the reversal in a COPD patient?
Neostigmine has a property of bronchospasm, making the patient
Bronchospasm.
bronchospasm.
Very good.
So uh,
Mm.
we, I mean, we need to give the glycopyrrolate before the neostigmine
Yes.
administration, sir.
So better to use them separately instead of in the available combination of myopyrrolate, so that the secretion as well as the stimulation by acetylcholine will be reduced by blocking those actions, and give it in a titrated fashion to check the adequacy of muscle power, and stop it at that level so that you don't have to give the regular adult dose of 2.5 milligram for all these patients. Because cystotracheurium is easily reversible, you can get back the muscle power with even lesser doses of neostigmine, which may prevent the post-op bradycardia also in the apart from bronchospasm,
Yes.
that also can be avoided. Okay, so these are all the things that you have to. And what are the post-op measures you have to take keep in your mind?
So the
Can you give the routine oxygen supplementation like any other people that patient undergoes in these cases? Supposing his pre-op ABG shows his saturation is only 85 or 90%. I mean, PO2 is only 85 or 90, and his PCO2 is always 55. Can you give the routine oxygen supplementation that you give for the normal patient?
It
So we need to
will
maintain the same saturation
You
levels
have to
as
give a
possible,
controlled
because that is
oxygenation
controlled
to
important
the
for the
oxygen.
patient,
patient.
because they are breathing because of the hypoxic drive.
Hypoxic
So
drive.
once you give too much of oxygen and block that hypoxic drive, then patient may stop breathing. Okay, so you should not order 6 liters or 5 liters of oxygen that you give for a regular patient with a Hudson mask should not be ordered. Even 1 or 2 liters should be sufficient to just maintain the oxygenation at the same pre-op level instead of trying to achieve 99 or 100% oxygenation. Okay, so that is one precaution. And another thing is pain relief should be adequate so that they don't hold the breath and go in for hypoxia and hypercarbia. Okay, so these are the two things that have to be kept in mind, and preferably nurse them in a 20 to 30-degree head up tilt so that the diaphragmatic excursions are facilitated well without restriction, and chances of basal atelectasis should be very much prevented. And early incentive spirometry or chest exercises and resuming the inhalation agents as early as possible will also help the patient to breathe comfortably and maintain the blood gases at the normal level or the preoperative level where he was tolerating. Okay, so these are all the points that you have to keep in mind in these cases. So again, I'll just go for the presentation.